So again, why imaging in bifurcation PCI? Because it's evidence-based, as imaging is for intervention, particularly significant complex intervention. This is a more recent data set from the British Cardiac Society database looking at 12-month mortality, IVUS-guided unprotected left main stem intervention compared to angiographic. We had an absolute risk reduction of mortality at 12 months with IVUS-guided intervention in a very large registry, not randomised, over 11,000 patients. And the added value of imaging is seen with operator volume experience. So as the operator volume increases, the IVUS-related prognostic advantage is exemplified. So again, it's not just imaging, it's actually integrating the information from imaging and applying it to the procedure from beginning to end. So if we specifically look at imaging with OCT beyond MLD max in bifurcations, it's a relevant algorithm, but I think there are some points to highlight with bifurcations. Pre-stenting, we really want to analyse the character of the plaque, main vessel, ostium, or the side branch itself, the need for modification, particularly calcium at the proximal point of the side branch, lengthy segment of calcific disease. We're thinking two-stent strategy. So it can help determine the strategy above and beyond a simple Medina classification on the angio, which really doesn't guide therapy necessarily, provisional or a two-stent. It allows us to select our main vessel and side branch balloons based on sizing, our stent size, and our pot size to oppose the stent in the main vessel proximal to the side branch with a provisional strategy and ensure we've got enough length from the carina to the proximal stent margin to do a pot. During stenting, we're evaluating the side branch, and important bifurcations with OCT where we're rewiring the side branch. In this case, is not a 2O diagonal, it's a circumflex artery to determine when we're ahead of kissing that we've rewired in a distal strut, not an extreme proximal strut. And finally, post-stenting apposition, but particularly expansion, is critical, excluding edge pathology dissections, landing in significant plaque burden, and again making sure we've cleared the struts from the side branch with an important bifurcation, left main as indicated. But expansion is the key thing. If the stent is expanding the lumen, holding the lesion close to or greater than the normal reference segment, the stent's expanded. And this is the key. MSAs, small MSAs indexed to the reference segments, predicate stent failure. We all see live cases performed angiographically, lip services given to imaging at the end of the case, comments made, it's round, it's on the wall, not one MSA is measured. OCT gives you this data automated, and it's very powerful. So we as mentioned, we prefer to get an MSA well above 80. Aluminum 4 required us to get over 90, which can be difficult, and we need to be pragmatic. Obviously, if we've got distal disease, we need to be mindful, but certainly proximal important vessels, we want to get optimal expansion. Because size matters, and this is retrospective data, IVUS Core Lab sub-study, 3 years outcomes from the XL study. Now, it wasn't an IVUS-driven study per se, but if we look between low and high tertiles of MSA in the left main, the higher and the bigger we get compared to the lower, we reduce the primary endpoint significantly, death, MI, stroke. We've got reduced mortality, reduced MI with a big MSA in the left main, and reduction in stent thrombosis. So this is not randomised. This is hypothesis generating, but it's clearly very relevant. And we know our optimisation goals in the left main with IVUS, with a complex intervention, what the minimum achievement criteria of an MSA should be. And initially, this is over 10 years data from Kang from South Korea. So this is a smaller body surface area population. The rules 5, 6, 7, 8. So a minimum MSA in the left circ prox is 5, 6 in the prox ostial LAD, and if the left main is 8. But in a Caucasian and a larger body surface area population from XL, perhaps 6 millimetres squared in the circ, 7 in the LAD, and up to 10 in the left main are our criteria. Now, moving forward with that concept, from Spain, De La Torre Hernandez has proposed outcomes of predefined optimisation in an IVUS-guided left main PCI as a prospective way forward. Now, this is the basis of the Optimal trial, and he's evaluated this retrospectively, as I'll show. But his recommendations are, initially with your simple left main intervention, ostial or mid-shaft, ensure we've got lesion coverage, and we want an MSA greater than 90% the distal left main reference for the stent. Now, if we've got a funnel-shaped left main, at least 80% of the distal reference. We want complete apposition. We want no proximal deformation of the stent, as can be induced with a guide and the like, and at the stent edges distally, landing in plaque burden less than 40%, no dissection. So the same holds for a distal provisional strategy. Again, greater than 90% proximal left main reference. We want now more than 90% proximal LAD reference. Again, complete apposition and not ending the stent in the LAD in plaque burden more than 40%, exclude dissection. And again, now for a two-stent technique, the same. We're looking now for not just 90% in the left main, but in the prox LAD and in the proximal circumflex artery, ensuring we're not landing in disease segment, leaving dissections, not having a deformed stent proximally. And this is an example. If we look at the diagnostic run, the still image of the angio in the middle, an equivocal distal left main stem lesion, certainly haziness, and we've got evidence of distal left main plaque rupture, moderate plaque in the mid left main, proximal left main reference 3.2 millimetres squared. We've got a proximal LAD landing zone 10.7, complex plaque in the proximal circumflex artery with a large plaque burden, but with a normal reference segment beyond at 7.2. So this was treated with a two-stent strategy. POT was performed, a kissing was performed, and a repot. So we've got good aorto-ostial left main stem coverage, but with the initial evaluation on IVUS, we've got an MSA in the distal left main, sure at 10, but indexed for 13.1, that stent expansion well below 80 at 76%. So re-optimization now gets an MSA at 12.8 millimetres squared, which represents 97%. The distal bifurcation left main, symmetric neocarina, excellent expansion in the proximal LAD compared to reference 90.6 and correspondingly 95% in the circ. So we need to measure. We need to make these measurements, whatever our tool is, whether it's provided automatically or not, because this is predicating optimal result. So what did Torre Hernandez do? He adopted this strategy with his IVUS Pro group, so this is a predefined optimization group, and he compared it historically to data from pooled registries with 124 matched patients, angio guidance, with 124 matched patients going conventional IVUS guidance. And compared to conventional IVUS guidance, the IVUS Pro group has bigger left main stent areas significantly, 11.8 versus 10, bigger stent areas in the circumflex and the LAD proximally significantly, expansion criteria met with IVUS Pro, 88% versus 65%, more complete apposition and importantly, less likely to terminate the stent with a plaque burden more than 40% at stent margin. So what does that mean clinically? This is a small study. I think the imaging is more powerful. It's underpowered for clinical events. Numerically in IVUS Pro in orange compared to IVUS conventional in green and angio in blue, we have reduction in left main TLR. If we look at the composite primary endpoint, in orange IVUS Pro compared to angio in blue, a significant reduction in the composite endpoint. But really we need to know what this means going forward, and this is the premise of Optimal, but importantly, an independent predictor of the primary outcome. Not only was age, diabetes a two-stent strategy, but it did include significantly the application of the IVUS Pro protocol. So as alluded to, this is going to be looked at prospectively, IVUS versus angio-guided PCI left main in Europe, from 3 countries, 30 sites, 2-year follow-up. Again, applying this protocol, some subtleties in terms of definitions of dissections that needed to be intervened on, including apposition. Here we're looking at the mandatory endpoint of the 5, 6, 7, 8 rule and the desirable over 90% expansion compared to reference in left main, LAD and circumflex artery. So I think this is an 800 patient trial, and I think it's going to be very important to look at the targets as assessed in this trial. So in summary, imaging in bifurcations is importance and of particular value given the limitations of angio. We can apply the MLD max algorithm, but can be bifurcation specific, evaluating disease extension, plaque morphology. We can plan our bifurcation intervention, guide the modification, choose our devices and optimise. But particularly IVUS guidance in left main provides a prognostic benefit over angio, but particularly when we use the protocol of predefined optimisation criteria. And as I mentioned, imaging guidance will only lead to improved outcome if we react adequately and integrate the data. So I'll thank you for your attention, and again, thanks for having me here.